Good evening. We'd like to welcome you to the Litvak public lecture, and of course I should begin by thanking Mr. Litvak for his generous funding for the Ethics Center to continue to invite people from the public to these lectures to inform them about ethics and to create dialogue. So I have the pleasure, and I should say, the Ethics Center has been committed with the passage of the End-of-Life Options Act to try and promote conversations and dialogue between clinicians and the public, and to begin to really think about how this impacts all of us. So this autumn, actually, the goal was to invite a few people, a few guests to come and lecture. And Dr. Sulmasy, fortunately, is with us this evening. And then next week, we'll actually, and you'll be, if you received an email or if you signed up this evening, you'll be receiving the emails about our talk next week with Linda Ganzini. So let me take a moment and introduce Dr. Sulmasy, although probably he doesn't need introduction to many of you. But Dan Sulmasy is from the University of Chicago. He's the Kilbride Clinton Professor of Medicine and Ethics from the Department of Medicine and the Divinity School. He's the Associate Director of the McLean Center for Clinical Medical Ethics and has an expertise in general internal medicine with a particular interest in end-of-life care. He's a member of the Presidential Commission for Study of Bioethical Issues, and as an ethicist and practicing physician, Dr. Sulmasy studies end-of-life decision-making, ethics education, and spirituality in medicine. In addition to serving on the editorial boards of several academic journals, he is the editor-in-chief of the journal Theoretical Medicine and Bioethics, and he's previously served as the chair of the Ethics Committee of the Society of the General Internal Medicine and on the board of directors for the American Society for Bioethics and Humanities. He's a prolific author and speaker, and he has lectured on ethics and medicine extensively throughout the United States and Europe. He is the author and editor of 6 books and has written more than 200 peer-reviewed journal articles on topics such as ethics of stem cell research, physician-assisted suicide, informed consent, and surrogate decision-making. So we welcome you, Dan, and we look forward to both the lecture and also conversation afterwards. Thank you.
Thank you very much, Catherine, for that gracious introduction. Thanks to all of you for coming here tonight. For those who were at the noon lecture, there's going to be a lot of overlap, so I apologize for that. It's a very different spin on it. It'll be less technical, less clinical, and hopefully speaking to a broader audience. As you heard, I am a member of the Presidential Commission for the Study of Bioethical Issues, so I have to start with my disclaimer at the bottom that these are my views that you're going to hear tonight, not those of President of the United States or the Ethics Commission. And I'm also in an academic institution required to give these disclosures in terms of potential financial conflicts of interest. I'm a general internist and a philosopher. I spent 25 years of my life as a Franciscan friar living under a vow of poverty. No manufacturers of drugs or medical devices have ever been interested enough in my work to give me any money whatsoever. I own no stock in any corporation other than I do own 1 share of the Green Bay Packers and 3 shares of the Seminary Book Co-op of Chicago, but I have no relevant conflicts of interest to report with respect to tonight's topic. So here's the outline. But before I begin, let me say that I think the topic is obviously a very controversial one, and that it's one that I know evokes passionate feelings on both sides of the issue. But what I am hoping to do is to urge all of us to try to think about these issues from an ethical perspective, to try to think as clearly as we can. I'm not urging us to discount our emotions, but to judge those emotions and to see which ones are morally proper and which ones need to be contextualized by ethical analysis. And above all, I'm hoping that there will be respectful dialogue. I have a strong position on this issue, so if you disagree with me, please don't shoot me. Let's talk. And if you're troubled by what I've got to say, or you're on the opposite side of the fence, as you heard from Catherine, Linda Ganzini will be here next week, and that lecture will probably be more to your liking if you don't like mine. So here's the general outline of what I'm going to do. I'm going to make some preliminary remarks about the question, and then I'm going to jump right into what I think are 12 bad arguments that are put out in favor of physician-assisted suicide. Then I want to give you 5 good reasons not to permit physician-assisted suicide. And then I'm going to go, and this is something I didn't do at noon, a little bit into what one should do in places where assisted suicide has been legalized if one is opposed. And I hope as many of you as possible will be convinced by my arguments that you should oppose it. And then to finally end up with the point, I think, where we all would be in agreement that what we want is good care at the end of life, and try to think about whether PAS really serves that goal. So that's the outline. I begin where I will end. I guess that evokes T.S. Eliot. If you know the 4 quartets, in the beginning is my end, and in the end is my beginning. But we all want, I think, good care at the end of life, both for ourselves and for those we love. And as clinicians, we want to deliver good care to patients at the end of life. And for me, what that means is being careful to withhold or to withdraw disproportionate life-sustaining treatments. When the ventilator is merely prolonging the dying of somebody, I want to say that I'm in favor, and I hope all of you are in favor of permitting the discontinuation of those kinds of treatments. I am also very much a proponent of hospice and palliative care, and I think that we ought to be treating patients' pain. There is a great problem with under-treating patients' symptoms at the end of life. There still is. There's growing awareness of the importance of good palliative care, but we have a lot of work to do. But I think that we all generally agree that we will permit that kind of care. I never want to say, this is an aside, I never want to talk about either aggressive palliative care or even aggressive cancer care, because I never want to be aggressive towards my patients ever. I talk about vigorous care. So we want to be vigorous in our care for patients at the end of life, treating their symptoms, even if, under something called the rule of double effect, we foresee the possibility that doing so might hasten their deaths. If it takes that much morphine to relieve their symptoms, I'm in favor of doing that, as long as my intention is to relieve their pain and not to hasten their death. And we'll go even further, and I hope all of you will agree with me on this as well, although it's a little more controversial, that even if it takes rendering the patient unconscious, we have to increase the dose of the medicine to the point that the patient becomes unconscious, what's called palliative sedation, that would be something that would be morally permissible and part of a package of good care for patients at the end of life. The hospice movement has been a tremendous step forward for this country. Many of you know that it was begun as a grassroots movement because doctors weren't doing their jobs, were not attending sufficient to the care of patients at the end of life, not attending sufficiently to them. And so nurses and survivors out in the field and a few courageous doctors began this movement in this country to try to improve the care for patients at the end of life. It's now become more mainstream than it was. It's merged with this medical subspecialty of palliative care, which functions mostly in the hospital, and not only at the end of life, but certainly attending to the control of symptoms for patients. These are good things that I am totally in favor of. Again, I think we need more of them rather than less. I am fully committed to treating patients as whole persons, as I suspect you are as well, and hope you are. That this is part of what good care for patients at the end of life means, that it means not only attending to their physical symptoms, but to helping them dealing with the psychological aspects of this and the spiritual aspects of their death. But my contention for the rest of the evening is going to be that physician-assisted suicide really ought to have no role in a package of good care for patients at the end of life, that it ultimately does more harm than good. So that's the strong position I'm going to take. So, let me start with the bad arguments that are given in favor of physician-assisted suicide. And I told you at the beginning I was going to be less formal than I was during the lecture this afternoon, and I'm going to start out very bluntly, informally. The first argument that's typically given in favor of physician-assisted suicide is this: who the are you to tell me what to do? Right? I mean, that's sadly, for me, what almost passes as a moral argument for anything anymore in the United States. And that strikes me as a very troubling state of affairs. That this is not, I hope you will agree, a good moral argument. But it's the one that's typically given as almost the first one, reflexively, by patients and other proponents. They can be a little bit more sophisticated than this, many are, but I've actually heard it this way. And it's been said to me in lecture settings like this. So, who am I to tell you? Let me just say simply that I'm a physician. I have taken an oath to care for patients, that I care for many who are dying, and I provide medical care for them, and I'm committed, and I hope every clinician in this room is committed to caring about the patients for whom we provide medical care, caring for them as persons. And I'm an internist, a general internist, but I'm also an ethicist. I have a PhD in philosophy. I think good medicine is always not only technically correct, but morally good, and that we need to think clearly about what we're doing if we're to provide the very best care for patients, whether they're dying or not, and ethics helps us to do that. But the who are you argument is just a bad argument, right? And I hope you'll all, sort of recognize that, even though it comes in sophisticated forms of, you have to recognize my autonomous preferences, maybe the way it's stated. But in the end, it's just a conversation stopper, right? Because then there is no attempt to dialogue about whether what you want to do is actually good. All law and all ethics actually restricts behavior, right? You could not go out on the freeway and drive in the wrong direction on the lane, right? And this is done it restricts your behavior, right? And people tell you what to do. And a police officer will tell you what to do if you're driving in the wrong direction on the freeway, or maybe the oncoming car that smashes into you will be the answer to that. Our actions are not ethically justified simply because we want to do them, right? I think that, that people have to really begin to reflect that saying, I want to do this, is the beginning of a conversation about ethics, not the end of it. The question has to be asked, why do you want to do that? What justifies that? If the aim of ethics, the aim of all the rules we have, is that we should flourish as individuals and collectively as a society, then we have to really think about whether what you want to do contributes to either your individual flourishing or the flourishing of the rest of us to whom you are connected. And the real ethical question is whether physician-assisted suicide helps patients to flourish at the end of life, and does it help the rest of our society to flourish, help us to be the best of what we can be as human beings. So that, I think, is not a good argument. Argument number 2. I just need this in my back pocket, right? People will say, I want to have it just in case things go wrong because they could, and I want to have it, and therefore the doctor should be able to give me a prescription to be able to end my life if I so choose. Well, I think it is not true that you will need it if you get good palliative care at the end of life. You shouldn't need to have assisted suicide if you've got good palliative care. People who, for instance, even in our hospital, I don't know if it's true in this one of the things that we've noticed at the University of Chicago, and I've heard anecdotally at other places, is that the advent of palliative care services in hospitals has decreased the number of ethics consults we get. Because they are thinking about these questions, helping patients and families to deal with these issues ahead of time. They treat the symptoms of patients, and in the outpatient setting, in hospice, the attention is given to making the final days of the patient as good as they possibly can be. By treating symptoms, by recognizing that and affirming for patients that we cherish them, even as the bonds that keep them and us together are slowly dissolving. And again, as I pointed out, symptom control, when necessary, can even go to the point of unconsciousness or hastened death. And I think that those are morally permissible, provided our intention is to relieve the suffering with a drug that's appropriate for treating that symptom and not to end the patient's life. And the data about assisted suicide really bear out that when the Gallup poll says most Americans are in favor of physician-assisted suicide, read the question carefully. It says, if a patient is in severe and unrelenting pain, would it be okay for the doctor to give them medicine to help end their lives, right? But that's not why patients, when you read the data, want to have assisted suicide. Uncontrolled symptoms is very low down on the scale. The questions, the reasons, the motives for asking for assisted suicide are to be in control, the fear of being a burden on others, or as the Dutch say, tiredness of life. Those are the reasons. And it's not that people are going to need this in their back pocket because there's no possibility that their symptoms could be controlled. In fact, we can, even if it takes unconsciousness, control patients' symptoms. So I think that if people think they need assisted suicide, then it's a failure of providing good end-of-life care. And if the system isn't giving us good end-of-life care, that's not a reason to commit suicide, right? It is a reason to try to make the system provide better care for patients at the end of life. And that's the real reason that you don't need to have this in your back pocket if we've got a system that's operating properly. Argument number 3, I've heard a lot of recently, well, the people have spoken. They've said this in Canada. They said this. I've heard Canadians say this about their Supreme Court decision. I've heard Californians say it. Well, let's look at that. It's actually not true in California, right? There were 2 failed referenda when they asked the people about this. It was enacted, actually, as you're more aware of than I am, by a kind of legislative coup during a special session on the budget, and sort of snuck in to that bill by people who were gung-ho about it with almost no debate. So if you want to say this is the will of the people, that's, at least in California, unclear. Second, not everything that's legal is ethical. And I hope you'll agree with that laws can be unethical. The mere fact that something has been made legal does not mean that it is good. Slavery was once legal in this country. Doesn't mean it was morally good. Jim Crow laws were enacted. Doesn't mean that they were morally good. And democracy, in the end, can make mistakes. It is the least worst system of government. That's what it is. I'm not in favor of any other system, but you have to recognize that it's a terribly flawed system. And recognize that Hitler was elected Duterte was just elected in the Philippines, right? So people can, I think, make mistakes when they use the democratic process. So the mere fact that something has been made legal doesn't mean that it's morally good. Argument number 4, very common. I wouldn't want this myself, or the doctor would say, I wouldn't do this, but I can't judge other people. I can't judge other people. Really? Isn't all law and ethics about making judgments? And the judgments that we make about laws and ethics are not judgments about the value of other people. Again, they're about the choices that we make and whether they, in fact, truly contribute to our common flourishing. I will say, too, that what we really want to do is be respectful of other persons. And a totally non-judgmental attitude, which one sometimes hears implicated in an argument like this, can actually really be indifference. Sort of, I don't care what you do, right? That's very different than I care enough about you to argue with you about this question. I really care, and I hope you care enough about me and are respectful enough for me that we can dialogue about it. So I don't think that the mere fact that you can get away from making judgments, certainly the best of clinicians are always making judgments that are always simultaneously technical and moral, right? This is the right treatment for you, Mrs. Jones, in my judgment, right? That's the judgment that we make all the time. And those judgments are the best ones that we make about what will help people to flourish. And so we can't get away from making judgments. We just have to make the right judgments. Argument number 5. Suicide is a private act that the government ought never to restrict. It's my body, my choice. My doctor and I want to do this. The government has no business interfering in our actions because it's purely private. My argument for this is that suicide is never a private act. A psychiatrist I know who used to be the chair of the psychiatry department at the Massachusetts General Hospital, Ned Kassem, was a liaison psychiatrist who said in a couple of lectures I heard, although I've tried to find him having it written down, but his clinical question, he said, for patients who were contemplating suicide was, in whose closet do you intend to leave your skeleton? Right? What does he mean by that? What he means is that suicide is an act of communication. It is always interpersonal. The person who is doing this is saying something to other people. You've let me down. The world has let me down. People don't care about me. And this is how I'm going to communicate that back to you. Studies have begun to show that there is post-traumatic stress disorder in doctors who perform euthanasia, at least. I haven't seen much on assisted suicide. In families who have witnessed euthanasia and assisted suicide. There are even good data about post-traumatic stress disorder in veterinarians who are doing this to cats and to dogs, let alone to human beings. Second, there's the phenomenon of copycat suicides. Again, if you say this is just me, it doesn't have anything to do with the rest of the world, recognize that when Derek Humphrey of the Hemlock Society published his book Final Exit, which was a how-to manual on how to commit suicide by either colluding with your doctor or stocking up drugs that the doctor gave you that you could use to commit suicide, advised people on how to take an overdose of drugs and to put a plastic bag over their heads so that they would be sure to die, because sometimes it fails and sometimes you vomit up the drugs. And there were good studies that were done at the publication of this book, Final Exit, that showed that depressed people were using that technique in order to commit suicide. There was a spike in this both in New York and then nationally a second study that repeated that. If you think it's a private act, It really isn't. It's affecting other people. There are data I showed a slide about this afternoon that in states that have legalized assisted suicide, the rates of suicide in the general public have increased. This is because it gets into the atmosphere. This is an okay thing to do. People are doing it. I should be able to do it. People who are depressed can think that they have now some sort of social approbation for doing it. There are far-reaching ramifications of the legalization of assisted suicide, both for medicine and for society at large. And in some ways, the idea that this is a totally private act is largely undermined by the demand to have it legalized. I mean, anybody can commit suicide, right? But what a lot of people want by having it legalized physician-assisted suicide is social approbation for this action. That society has said this is a good thing to do. And the physician assistance tends to medicalize and to socialize and to cover this with the cloak of being medical care. But obviously that by itself argues against the idea that it's a purely private act if you want somebody else to help you. In fact, the Stoic philosopher Seneca thought that suicide was okay, but assisted suicide or euthanasia wasn't, because you weren't a good Stoic if you needed somebody else's help. Right? And so even the idea of legalizing it already contains within it the idea that it is not a private act, because people want more out of it than that. Argument number 6. Well, suicide is legal, right? So why shouldn't physician-assisted suicide be legal? Be careful about this, too. Suicide has been decriminalized, and that's not quite the same as saying that it was legalized, right? The vast majority of people who commit suicide are psychiatrically ill. Most of them are depressed or have other psychiatric illnesses. And what was happening, there were laws in the books for many years that treated someone who had attempted suicide as if they were a criminal, and it wasn't being treated as a mental illness as it ought to be. And that's the reason why laws were passed to say that suicide is not a crime. That's not the same as saying that suicide was legalized as if society was trying to encourage people to do it or to permit them to do it. It was to take away this sort of stigma that was adding to the stigma of mental illness. And assistance with suicide was kept illegal when this was done to prevent abuse, to prevent family members or physicians from aiding a person who might be suicidal from actually carrying it out. And that was often done because of suspicion somebody might do that for nefarious reasons. And that's the reason that all the laws have been passed. So to say that suicide is legal is a bit, I think, of a mischaracterization of the decriminalization and the motives for it and the reasons that it was done. Argument number 7. We can keep this safe, legal, and rare. Language we've heard in other aspects of the political and bioethical sphere. Oregon is offered as the model for this, and you'll hear Dr. Ganzini, and you can question her more directly yourself next week. But the studies that have shown that there's no abuse are basically saying that no poor black people are availing themselves of assisted suicide. Therefore, there's no discrimination. There's no targeting of the poor or minorities. But that's not really sufficient evidence. First of all, if you know anything about the difference demographically between California and Oregon, there's an explanation a partial explanation for that just right there. But even if there were a lot of African Americans or Latinos and more poor people living in Oregon, that's not sufficient to sort of say that all is okay. For instance, there are high rates of depression, and Dr. Genzini herself has done these studies, and almost nobody is referred for psychiatric evaluation. In fact, there's one physician who approves all the people who come to him asking for it, and he accounted for 10%. He accounted last year for 10% of all the lethal prescriptions written in the state of Oregon. So there are a few people who are actually specializing in this. In fact, at I recently at ASCO, the American Society of Clinical Oncology, debated Tim Quill about this topic, and one person in the audience, I think, identified himself as that person. He says, "This is all I do, is assist people with suicide. That's his medical specialty." And the rates, actually, while they're small, it's true that a small fraction of people are looking for this, are gradually rising in Oregon. But I think Oregon is just the beginning, and if all seems to be well in Oregon, and I'm not sure it is totally, I think you have to recognize that Belgium and the Netherlands are the destination for this. In Belgium and the Netherlands now, 5% of all deaths are from euthanasia. 1 out of 20 people who dies by a lethal injection. That's higher than people dying of HIV, for instance, as a fraction of the population. And they're opting for euthanasia, not assisted suicide, because it's much cleaner for the doctor to do it, and I think there'll be increasing pressure once PAS is legalized to move to euthanasia. There's neonatal euthanasia in the Netherlands, the Groningen protocol for how to do this. There's psychiatric euthanasia for patients who are psychiatrically ill, saying there's even a case in Belgium of someone who was distressed at a sex change operation not going as well as asked for, as desired, and being granted permission for euthanasia. There's non-voluntary euthanasia of the demented who haven't asked for it, but people are saying, well, we could reasonably believe Grandma would have wanted this, so let's do it. And there are even euthanasia vans for people who can't make it into the hospital that go around from place to place. I think that's more what our destination will be. And if you say it can't happen here, that we'll be different, that we're so radically different from people in other countries, I think you're just naive. It can't happen here is not a very reliable moral argument. Argument number 8. Doctors have to do this. They have duties to relieve suffering and not to abandon patients. Well, it seems to me it's odd that we failed to recognize this for the last 2,500 years in Western medicine and seem to have gotten along pretty well. And it's also odd that it should arise now when we can do more than we've ever possibly been able to do to care for dying patients. We can do TENS units, nerve blocks. We can add adjuvant tricyclics to our opioids. We can give intrathecal opioid drugs into the central nervous system. I mean, there are all kinds of things we can do if the problem is symptoms. So it just strikes me as very odd that this is the time that people are asking for it. Non-abandonment, I'll agree, is a moral duty for physicians, but it means accompanying the dying, walking with them and affirming their value even as they're dying, not accommodating every single wish they have, right? It means to be with people, to not abandon them. And even if someone asks me for assistance with suicide, while I will tell them that I won't do it, I simultaneously promise that, I'll do everything I can short of that to help you with all your symptoms, and I'll be with you if you want to keep me as your doctor, and I hope you will to the very last. I'll be with you. That's what non-abandonment means. And relief of suffering means eliminating, where possible, the occasions of medical suffering. It doesn't mean eliminating the sufferer. And that's what medical relief of suffering ought to mean. And that's our duty, and I'm committed to relieving the occasions of medical suffering, not to eliminating sufferers. Argument number 9. There's no difference between killing and allowing to die, so how can you justify a ban on assisted suicide? If we take people off ventilators, we know they're going to die. Why is it so different if we give them a prescription for a lethal drug? First, you should recognize that that's an argument. If there's no difference between killing and allowing to die, that's not just an argument for assisted suicide. That's an argument for euthanasia, right? There's no difference. So if you're committed to assisted suicide, on that basis, you ought to be committed to euthanasia. Second, I think it's mistaken that there is I think there is a difference between killing and allowing to die. Common sense reasoning recognizes that there's a difference, I think, between injecting a poison and turning off a ventilator. But common sense is a complicated thing to explain to philosophers. Philosophers always want simple criteria, yes or no, as black and white as possible. There's actually a famous Franciscan philosopher named William of Ockham. We use this in medicine all the time, Occam's razor, economy of reasons, economy of explanation. The simpler, the better. But common sense reasoning is complicated. And here's what I think the difference between killing and allowing to die actually is. To kill somebody is to create a new lethal condition in that person, intending that he or she should die, whether that's putting a bullet through their heart or injecting a poison. It's creating a new lethal condition with the intention of making the person dead. Allowing to die means foregoing an impediment to the progression of a pre-existing lethal condition. So when we turn off a ventilator, that's what we're doing. The person has an underlying condition which leads to their death. We have a treatment which has been slowing the progress of that down, and I think it's morally permissible in many occasions to discontinue that treatment and allow the underlying lethal condition to run its natural course. The way we phrase it, if we're really sensible about it, is that all killing of patients by doctors is wrong. Some allowing patients to die is ethically permissible. Some allowing patients to die can also be ethically wrong. I gave the example today. If I thought that I stood to gain $1 million if a patient died by midnight and they come into the emergency room and I know that the McLean Center for Clinical Medical Ethics is in their will, and I decide not to put them on the ventilator when they need it, I might have allowed that patient to die, but I could have done it for, in that case, a wrong reason, right? There are good reasons. We use them frequently in medicine and medical ethics. The patient is close to death, the burdens of the treatment outweigh the benefits, it's futile, it's causing more harm than good, it's only prolonging their dying. Those are good reasons, and the patient says, please stop this, and they're in agreement with that if we suggest it. Those are the morally acceptable reasons for doing it. And our intention, again, in those conditions is not that the patient should die, but that the treatment should stop. And we are satisfied when the treatment stops. If the patient starts breathing after we discontinue the ventilator, we don't say, oh, I failed, let's go out and get a pillow and smother the patient, right? Our intention has been satisfied when the patient and the ventilator are disconnected. Okay? Intentions matter in ethics. In fact, perhaps the first moral judgment that one sibling makes about another is what? You did that on purpose, right? Right? We are constantly reading each other's intentions and making judgments about those intentions, and they matter in ethics. And from a legal perspective, U.S. courts have systematically, including the U.S. Supreme Court, recognized a difference between killing and allowing to die. So I think there is a defensible difference between those two, and that's why I think it's morally permissible to forego life-sustaining treatments, but we can say that it is not permissible and be logically consistent by saying that it is not permissible to assist a patient in suicide. Argument number 10. Well, isn't this justified when the patient has lost her dignity? Dignity, however, is a fairly ambiguous term, right? So the Oregon bill that legalized assisted suicide was called what? The Oregon Death with Dignity Bill. And why did the people who objected to it object to it? They said it was an affront to patient dignity to kill them, right? So people can't be using the word in the same way, right? It's an ambiguous term. The way I'll unpack that is to say that there are two ways of using it. One is an intrinsic sense of dignity, the value that a human being has by virtue of being a human being, the value a patient has by virtue of being a human being. And that's different from attributed dignity, which is the value we confer on ourselves or we confer on other persons. So when somebody visits from another country and they're high up in the governmental hierarchy, we call them visiting dignitaries, right? They've got this sort of status that we have conferred on them. That's an attributed use of the word. Martin Luther King, in promoting civil rights in this country, talked about intrinsic dignity. And the way he did it is he said he learned about it from his grandmother, who told him, Martin, don't let anybody ever tell you you're not a somebody. Right? That being human, being a somebody, is all that's necessary in order to have dignity, which is radically equal and inalienable, and the same for you, and the same for every patient you see, and the same for me. It's the value we have simply because we're human. And it's in the end the foundation of all human rights, and I think the foundation of ethics, that we recognize this value in persons. There is no doubt that illness and injury can attack a person's attributed dignity, right? It is painful to see somebody who's, let's say a professor of biochemistry who's now incontinent and ventilator dependent, right? I mean, illness can do those sorts of things to people. But the most fundamental ethical question in assisted suicide is whether a medical condition of any sort can rob a person of his or her intrinsic dignity. And I think the answer is no. The reason we are reaching out to help them in any sense, to treat their symptoms, to do anything for them, is because we first recognize them as human beings who bear this value. That's the reason I went into medicine, is that I think all patients are persons. They all have value, whether they're dying or whether they're going to survive. And that value is their intrinsic worth or dignity. And if you say that there are safeguards that would be put in place in these laws, and there are in the California law, recognize that they both require decisional capacity and that the patient have a terminal condition. So when people say someone's robbed of their dignity by an illness, they're usually thinking about dementia, right? But the person who's demented, who has lost decisional capacity and is not yet in the last 6 months has lost decisional capacity, can't give informed consent, which is required by the law, right? And if they want to do it in anticipation of the possibility, then then they still have decisional capacity. It's in advance of a 6-month terminal prognosis, so they're ineligible under those criteria. So there's no way in which a person with dementia, which is the one condition that people imagine being the reason that you would do this because they've been robbed of dignity, can actually, by the safeguards that are built into the law, technically be eligible to participate. Unless you fudge those safeguards, and then you have to say, what are the safeguards? What are the safeguards? Number 11, the only opposition to physician-assisted suicide is religious. It's a bunch of those fanatics who are, think that people were created by God, who believe in this, but sensible people don't believe that. Well, I think it is not true that the only way to argue against euthanasia and assisted suicide is religious. I will challenge any of you to find in any of what I will say tonight a reference to deities, religious texts, religious teachings in any of the arguments I've given you or will give you for the rest of the evening. Philosophers, pre-Christian and anti-Christian, from Aristotle to Kant to J. David Velleman, have made arguments against the legalization of assisted suicide, or against suicide anyway. Aristotle didn't have to worry too much about physician-assisted suicide. It wasn't quite an issue in his day. Euthanasia maybe, but not assisted suicide. There are law professors who are not religious who have argued this. Yale Camazar began in the 1950s a famous article that's called, 9 non-religious arguments against euthanasia. Bo Bird, the late great law professor at Yale, not a particularly religious person, as opposed to assisted suicide. Physicians who are not famous physicians involved in end-of-care life who are not particularly religious, from Ezekiel Emanuel to Ira Byock, are opposed to this. So you don't have to be a religious person to argue against it, and the arguments I'm giving you are all non-religious. What this sort of accusation really amounts to, I think, is a kind of subtle ad hominem argument. It's trying to say that people who are religious are really daft, and we're going to paint everybody with this brush of being religious, and therefore irrational and not having a place in the marketplace of ideas. But I don't think you have to give any religious arguments, and I'm not giving any tonight, to argue against the legalization of assisted suicide. Argument number 12, momentum has swung, get with the program, right? California, and what Compassionate Choices says now, 1/5 of the population now has access to assisted suicide. It's here already, get with the program. Well, first of all, it's not true that momentum has swung as enormously as is being suggested by the propaganda. Just since California enacted its law, 22 state legislatures have rejected bills introduced in those state legislatures. The American Medical Association, the American College of Physicians, the World Medical Association all remain opposed to this. There is bias in reporting about this. The news people will say, well, if the state legislature in Denver backs or rejects a bill on legalizing assisted suicide, that's not really national news because it's just the status quo. There's nothing new there. It's only if they do something really interesting and new that becomes newsworthy, like passing a bill that legalizes it, that we would report it. Well, if that's a bias, whether it's a good, whether it's truly just about what's newsworthy or whether it reflects other biases, that's what happens. The status quo doesn't get any reporting. That's why you probably don't even know about it. Many of you probably don't even know. You may have heard that New Mexico, because it got national reporting, at a lower court level had said that assisted suicide was against the state constitution. There was almost no reporting, and probably many of you don't know that just a few months ago the New Mexico State Supreme Court rejected that argument and said it is not unconstitutional to ban assisted suicide in New Mexico. No reporting on it. No reporting. Medical journals, I will tell you it is extremely hard to get anything into the medical literature these days that expresses opposition to euthanasia or assisted suicide. That's anecdotal. It's my experience. I don't think I'm a bad writer. I don't think I have a reputation of being somebody who's not competent in doing ethics. I've had an incredibly difficult time getting anything published in any major medical journals because they say it's unconvincing, it's not new. What would be new would be something that's in favor of euthanasia and assisted suicide. That changes the status quo. That's progress. That's a bias, and it makes it seem as if the momentum has swung. And if you think that the momentum has swung is a reason for jumping on the bandwagon, then that's not a good logical argument either. It's what's called an argumentum ad populum, right? Which your mother told you probably when you were growing up is not a good moral argument. If just because everybody else is doing it doesn't mean you should, right? That's the simplest way to think about it. But we somehow get all confused and say we need to do this. Think about it from a moral point of view. Think about it from the point of ethical analysis and rational argument. That's not a good reason to legalize it just because other people are legalizing it. So, why should we have a ban on assisted suicide? The number one reason I'll give you is that I think it's bad medicine. It ought not to be needed from a strictly medical point of view. I think it distorts the meaning of healing. Restoration, for instance, is a canon of therapy for all that we do for patients, and eliminating a person is not restoring that person, right? That's not healing. We also want to be respectful, I think, of the bounds of medicine. Paul Ramsey, the early bioethicist, once said that the function of medicine is not to relieve the human condition of the human condition. Right? It is not our job to relieve all possible suffering for everybody. So if somebody says, I am tired of life, it is not the job of the doctor to end that suffering by something that's in their black bag. You've got to be respectful and humble about the limits of medicine. And given the enormous power imbalance between physicians and patients, I think this is a power we should not want, because it actually, I think, will prove toxic to us. Reason number 2 is the physician-patient relationship and how critical it is to maintain trust in the physician-patient relationship. And the minimal conditions of trust that establish the bounds necessary to sustain it are these, which go back to Hippocrates, right? Someone is going to come to me as a patient. They're going to bear their body to me. They're going to bear their genome, perhaps, to me. They're going to bear all kinds of secrets they wouldn't tell anybody else. So I've got to pledge to them and make sure that they know that we're in a safe space where they can do that. And these are the boundaries. I will not divulge your secrets. I will not have sex with you, and I will not kill you. Those are the minimal conditions that establish the boundaries that make this kind of trusting relationship possible. And we ought not to say that we will transgress those boundaries. And I worry deeply about the phenomenon of countertransference, by which clinicians can have their own issues dealing with death and dying and disfigurement and incontinence and the other kinds of conditions that patients that they see can be in. It is also, and the ways in which that can be subtly transmitted to the patient through body language, through other kinds of subliminal kinds of communications, even subconsciously, and interjected by the patient and presented back to the doctor as if it were the patient's own autonomous choice, when it's really just mirroring what they hear from around them from this power figure of the physician. It is also true that caring for the terminally ill is terribly difficult work. It's much easier to end it. And physicians, sadly, but if we're honest with ourselves realistically, have these kinds of subconscious fantasies about being rid of patients. There's a great sociological book that was written by a sociologist who was a participant observer at a hospital, an unnamed academic hospital in the southeastern United States. And this person, who was a sociologist, just walked into a general medical service, hung out there for a year, took field notes, talked to people, and the title of the book was Getting Rid of Patients. Because that's what we do. We discharge them, we get the DNR order, we get them out of the hospital, and please, let's not add to that, or we give them the lethal prescription. Reason number 3, the social and ethical implications of assisted suicide for the entire society. The value of persons that I talked about before, this sort of somebodyness, is critical to the moral fabric of our society. To assist someone in killing herself is to endorse that person's view that they are better off being dead and that we are better off without them, that their life has lost its meaning and value. You have to come to that conclusion if you think it's okay for them to kill themselves. And that makes a somebody into a nobody and violates that intrinsic sense of dignity. Now, as you probably know, the people that have been most worried about the legalization of assisted suicide are the disabled. And I think in the end it's not so much about their fear of abuse. I think they do have reasonable fears of abuse. But I think primarily what they don't want is the social endorsement that legalizing assisted suicide for reasons of lack of control, lack of dignity, because they're in diapers or dependent upon others, or in a condition of disfigurement, means that we are capable of disvaluing them, because they can be in the same condition. And that's what I think is really deeply morally at stake in these questions. The philosopher Wittgenstein once wrote that if suicide is allowed, anything is allowed. I think ultimately its autonomy run amok. The patient wants it, therefore we ought to do it, is not sufficient justification. If that is true, then all of this talk that we have about doing value-based care, doing rational care at the end of life, or at the beginning of life, or in the middle of life, goes out the window. How could you argue against demands for fetal care? Patient wants it, we have to give it to them. How could you argue about antibiotics for a viral URI? Patient wants it, we've got to give it to them. That is too dangerous to give up. The mere fact that somebody autonomously asks for something is not sufficient to justify it. It may be necessary. You don't want to do things to patients against their will, but it is not sufficient. Reason number 4, the possibilities for abuse. I already talked to you a little bit in Oregon about the lack of psychiatric referrals, the fact that there are assisted suicide specialists who come no questions asked. You want this, I'll do it. There's also evidence of underreporting and some skirting of the rules. Well, we gave this person with ALS, Lou Gehrig's disease, the pills in their pudding, and then we held it up to them and they swallowed it, so we didn't really euthanize them. We just assisted them in their own suicide. Reason number 5 is the slippery slope. I spoke about this at greater length this afternoon, but once you have legalized assisted suicide, I can guarantee you that once there are a sufficient number of cases or states that have done so, the clamor will be there for people who are paralyzed to have access to death, and if they are paralyzed and have a trach tube and can't swallow, then they're going to have to have euthanasia. And it will be argued that it's discriminatory if someone is dying and can have access to the pills to kill themselves. Why can't this person, who may be even worse off than them, have access to death? And then we will go to the point of having non-voluntary euthanasia, substituted judgment that grandma would have wanted this. We could tell we know her well, and to not give her equal access to this as persons who are competent is discrimination against grandma, who ought to be able to get exit for this. And I think that's going to happen with great rapidity once enough states have legalized it. Nobody wants to do it now in the pro-euthanasia, when the pro-assisted suicide movement wants to push that agenda, because it will, if that starts to happen, it'll argue against their idea that it could be contained to assisted suicide, so they're not bringing the cases. The psychological slippery slope for physicians. A scary film I once saw, a Dutch physician said it was hard the first time. Once you pass that barrier, it becomes easier to do things that you might have thought were immoral. And then lastly, the social and the economic pressures that we brought to patients for whom dying can become not just an option but a duty. And I worry deeply about that. Once it's legalized, that I think is going to be the default switch. So those are the reasons I'm against it. But what should you do in places where assisted suicide is legal? Well, I would argue this, and I think that most people are just capitulating and sort of saying, we'll make the best, as the British say, of a bad job. Even if you're against it, we'll just try to sort of limit it. But I don't think that's enough. I think from the medical point of view, medical ethics point of view, we should treat it like capital punishment. It may be legal, but we should oppose it, and we should not allow physicians to participate in it from a moral perspective. I know there are some places where people are complaining they can't get access to this. I say good, that's what we ought ought to be doing. We should resist doing something if we think it's morally wrong. Don't refer patients for it. Speak out against it. Don't just capitulate. And I would argue that you ought to fight to repeal the law. Bad laws are passed. Bad laws can be repealed, and I think this is a bad law, and that's what I would be doing if I were here in the state of California. Instead, I'm just coming and instigating. But let me emphasize again, where I hope we all agree, that we want to care for patients and give them the best possible technical care, but we want to do so because we care about patients as persons. We want to manifest that care, especially at the end of life. We want to commit ourselves to improving palliative care, making hospice more widely available. We want to fight against the continued unwarranted use of life-sustaining interventions that are futile or more burdensome than beneficial. But I think assisted suicide is just a distraction from all of that. And we spend so much time giving lectures like this. Believe me, I would rather be giving you a lecture about why you should be giving more morphine to patients who are in pain than trying to fight something like assisted suicide. In the end, what we have to do is keep our eyes on the prize. Our prize is always the patient. This is the famous painting of Sir Luke Fildus, which is called The Doctor. The doctor is looking at the sick child, who may even be dying in this picture. His focus is on that person as an individual, valuing him or her, even as the bonds that keep her and the rest of us together are slowly dissolving. And it's ambiguous where the father is looking. I think he's looking at the relationship between those two. That special relationship and the trust that's necessary for medicine to actually do its job. And I think assisted suicide distorts this picture, which I think is the right picture of the kind of medicine we want to give our patients. So thank you for your attention. I know it's been controversial. I imagine there are a few people who might disagree with me. If you have some point of agreement, I'd appreciate hearing that too, but I'm happy to entertain questions, comments, and objections. Thank you. Yes, ma'am.
Handle this, there was actually some evidence that the family had less PTSD. They grieved appropriately, but they had honored their loved ones' wishes in the state of PAS instead of euthanasia. So that's comment on that. And the second place where I'm struggling, and I'm also a family physician, so as a physician, and I have to say, 30 years in medicine, I think all of us could step back and imagine that patient that we've had, where the amount of suffering at the end of life is not physical, not religious, but it's something with which you kind of absolutely can't characterize dignity. But in that sense of who they are as a human being, their own characterization of who they are, not someone else's characterization, this is insufferable to be having this experience, and their loved ones are honoring them. So whether we call it dignity or an insufferable suffering that is not released in normal forms,
Okay. Thank you. Good questions. Do I have to repeat them here, or did everybody hear the question? Or okay, good. So the first one regarding PTSD. Yes, the evidence I was giving, and I think I initially might have said assisted suicide, and then I tried to correct myself that the evidence is euthanasia. It's largely from Belgium and the Netherlands. and that's the same for the veterinarians' PTSD. It's euthanasia. I'm not sure that if we did more careful, I've seen the one study. I'm not sure it was a good one. I think it was a small sample size too on PAS. So I don't know that we have good evidence about assisted suicide. I just think we don't. That's still an open question. It may be, in fact, particularly if it goes awry, which is more likely to do, even more traumatic, right? The person begins to vomit, etc. I think it can be even more traumatic. But I don't think we have the evidence about PAS, just for euthanasia. Second, regarding what I characterized this afternoon as the medical burning lorry case, right? The British philosophical literature. You've got somebody who's stuck in the truck, right? It's burning. You can't get them out. You've got a gun. Isn't the most merciful thing you can do to kill them? And you're sort of giving a sort of existential version of the burning lorry case of the person whose suffering is, unrelievable. I think what I, caution there is to suggest again that medicine has to at some point recognize its limits, and that's good for society, and it's good for physicians to recognize limits. We get incredibly frustrated when we can't fix things, right? And that patient you're talking about, is what drives physicians to sort of say, I need to be able to fix this. What I think good physicians ought to learn to do is to be able to sit with their limits and recognize that, as Ramsey said, the function of medicine is not to relieve the human condition of the human condition. I would not abandon that patient. I would continue to care for their symptoms as best I could, to offer whatever assistance I could for their existential suffering. But I would only use means that are appropriate to the problem. Right? There is no indication, if you look under secobarbital in the physician's desk reference, you don't see existential suffering as an indication, right? And if we won't do it for somebody who is not dying, why does medicine suddenly think we ought to be able to do it for someone who is dying, to give them a lethal dose because they're tired of being alive, right? Or the mere fact that they're not dead yet is causing grave distress. And so I think we just have to become more comfortable with recognizing and being more humble and sort of saying that we need to sit with this, right? I'm thinking for a moment of the poet from Bengal, Tagore, who says to be able to sit still with the joy that can sit still with the open red lotus of pain, knowing not a word, right? That we need to be able to teach physicians to have that kind of equanimitas, to be there with people, to not abandon them, to care for them, to do what we can to ease their suffering, but not to think that we can, provide a quick fix out of our, pharmacopoeia for the problems that are inherent to being human. Yes.
So it's my understanding of part of the process whereby this became lawful in the state is that the California Medical Association reversed its historic position and adopted a position of neutrality.
Right.
What does this tell us about, what should we read into what this tells us about the medical profession today, in contradistinction to the way that perhaps medicine has always seen itself? And should we be worried?
Yes. Good questions. First, the first comment in reaction to that is to recognize, and medical associations all over the world where people are pushing to do the same thing as California have to recognize this, is that neutrality is not neutral, right? How was the national coverage of the CMA's position read? CMA drops its opposition to assisted suicide. It is not neutral. And anybody who claims that is giving in to political forces that are trying to push for neutrality as a way of getting that headline so that they can push forward with a political agenda. Second, at the deeper sort of level of your question, yes, I think that medicine, the mere fact that something has been part of a tradition is not sufficient to say that it is morally true, right? So that's a historicist version of, if you will, of the naturalistic fallacy. But we should not be so critical as to think that 2,500 years of accumulated wisdom from all of the people who've been doing medicine before us doesn't have something to say to us. And to reject that, or to think that we are so much smarter than Hippocrates because we're living in the 21st century, is, I think, arrogant, actually. And it's becoming more common in sort of rejecting the sort of the corpus of the sort of dead white males who dominated Western thinking for so long, and there's some reason to be critical about that. I wouldn't say I would be an uncritical defender of the tradition, but there's also something to say that there is wisdom in tradition, that people who've been doing this before us for 2,500 years have something to teach us, that there is wisdom in the Hippocratic dictum that we should honor our teachers, that we are part of a chain that has passed down this knowledge and how to care for patients over centuries, and we do ourselves a grave disservice to cut ourselves off totally from that tradition and say we know better and everything that went before us is irrelevant. It isn't. We are embedded in a history. We ought to understand that history and learn from it, not uncritically, but accept that they have some things to teach us. Yes, Roberto. Yes.
Thank you, Dan, for your presentation, which I think is striking, first of all, because it talks about assisted suicide.
Mm-hmm.
And physician-assisted suicide. And that's very interesting because in a way that language has completely disappeared, in fact, in California. Certainly disappeared from the path of discussion. We rather talk about aim to die than physician-assisted suicide. That this is obviously a kind of semantic trick is quite apparent. But the question I have is that in a way, focusing on the issue not in terms of physician-assisted suicide, rather in terms of aim and die, takes away the attention of the fact from the fact that what is really at stake in the question of physician-assisted suicide is, first of all, the question of the morality of suicide. And then, of course, the question of what does it mean to attend to somebody else's willingness to commit suicide. So I guess my question for you is, why do you think we have somehow internalized this sort of semantic?
Yeah.
We have been sort of unwilling or unable to throw into view the fact that we are not speaking true what in fact we should be speaking about. Secondly, why do you think that has been especially the fault of physicians, who I think have not really been willing to resist that kind of language. But in fact, even when entering the conversation from a polemic, meaning a critical point of view, have not always been willing to criticize once again these semantics.
Yes. Very good observation. I probably should have had a slide just on the language as well. Maybe that's the 13th argument. Yes, the sort of first of all, people, I think in general in our society and particularly in our professions are increasingly unwilling to really try to think critically about these questions. And so when you look at it, the semantic trick you're talking about actually has been known for a long time. It's an informal logical fallacy of begging the question, petitio principii, right? One of the questions at stake is whether the spectrum of services that we ought to offer for good end-of-life care includes assisted suicide or not. And when you call it aid in dying, you have already included all of it under the umbrella, so it has already contained the conclusion to your argument in the language that you're using as the language. The other reason that's given for it also is striking. If you talk to Tim Quill and others, well, we don't want to say suicide because that stigmatizes the person who does it. Wow, what does that say about all the psychiatric people who are already stigmatized? It's okay to stigmatize them, but not me because I'm doing something rational. That's pretty striking as well, and sort of self-centered in its own way. So I think that this is a way in which people want to win the debate by not advancing actual ethical arguments, but just changing the semantic terrain so that it seems like it's okay. And that, I think you are absolutely right, is something we ought to always be wary of, but particularly in something like this, because it's a technique. I mean, look at what even the organization Compassion and Choices, right, keeps changing its name, right? The Hemlock Society, the Society for the Right to Die, right? Compassion and Choices. I mean, they're always trying to find, euphemisms for what they're advocating, and that's propaganda. That's not actual critical thinking and moral argumentation. You are right as well that when you take the word suicide out of the equation, you are glossing over the reality of what's actually happening and glossing over the real moral question, which is the morality of suicide. Suicide, if killing means creating a new lethal pathophysiologic state in someone with the intention of making that person die, then when you do that to yourself, that's the definition of suicide, right? You create a new lethal pathophysiologic state inside you with the intention of making yourself dead. That's just a description of what it is. I'm willing to argue with you about whether there are cases in which that's rational or justified, right? That's where we ought to be talking. We shouldn't be sort of, sweeping that away with basically propaganda so that we can get to the nubbin of that question. I mean, David Hume didn't shy away from calling it suicide, right? John Donne didn't shy away from calling it suicide, and they made arguments that they thought there were cases in which it was justified. All right? Well, let's argue about that. That's what I want, is a transparent argument. I think it's what you want as well. Why are physicians adopting the language? Maybe some of this is the increasing way in which we are being transformed subtly ourselves into providers of a consumer good, and we satisfy the preferences of our consumers. And if this is what the consumers want, and this is what the consumer wants to call it, then we're willing to do it. I mean, I think we are increasingly being deprofessionalized and not thinking about our own tradition or our own ethics vis-a-vis the marketplace morality that's been imposed on us, and again, we've just become willing acceptors of that, and this is just, I think, one more instance of it. You want you want this, that's good, and if we don't give it to you, our Press-Ganey scores are going to go down because the satisfaction scores are going to go down. Therefore, we've got to do it so we can maintain our place in the market, right? That's sort of everybody's sort of imbibed that, and I think that may be one of the reasons, among others. Among the other one I gave is the sort of just general sloppy thinking that is, or unwillingness to engage in this kind of critical thinking that's crept into the professions. Good question, and sorry for a long-winded answer, but it was a good question with multiple parts. Nothing less would be expected of Roberto De Loro. So. Yes, David. Yes. Yeah. Yeah.
Thank you so much for coming to California.
Happy to be here.
There's a question given the vaccine that my colleagues and I have been kicking around about how the availability
Yes. Yes, no, it's a good question. My view about resistance gives you a clue that I would not endorse that. But I think a lot of people will think that way. I think they already have, and that's part of why I suggested that the mere existence of this law changes the default switch. It's on the table. It is looming now over the doctor-patient discussion, the nurse-patient discussion about end-of-life care. And many people are going to sort of say, it's on the table. It's one of the things I need to offer. I don't think we have to mention or offer things that are immoral. And if somebody wants to put me in jail for not doing that, I will go to jail because I think this is so fundamental to the morality of the profession, the morality of our society. People can find out how to do it, and they don't need. Somebody else asked this morning. Why do physicians have to do this? People don't need doctors to kill themselves, right? They can do it quite readily by going into the garage and turning on the engine and just sitting there. I don't want that to happen. I wouldn't encourage somebody to do that. But they don't actually need me. What I think people are after is the sort of social approbation for this. And our mentioning it is powerful. Our mentioning of it means that it's something that we ourselves would be willing to at least endorse, or it implies that. And I think that's powerful and really problematic. And it's one of the things that I think is very troubling about the law, that many people are going to think they have to. I would not. Yes?
Thanks for a very interesting talk. I guess it's reflective of the interest that everybody has. That I attended a lecture today over our colleagues at Cedars-Sinai, where they had the director of health from Oregon.
Mm-hmm.
Several things really struck me. One was the increase in the number of people who are both choosing the option and then carrying through with it. And it kind of surprises me after this period of time that we continue to see an increase. The second thing, though, that she pointed out in their statistics was the decrease in the number of physicians who are present at the person's death. And I really am reflective of the picture that we still have up on the screen that basically reflects the position of being removed from the scene. Mm-hmm. And I find that troubling. Mm-hmm. The other thing that she mentioned was her concern about people starting to fudge. Mm-hmm. That you had mentioned this, and I guess it's part of the slippery slope argument of people who are fudging whether someone is terminal within six months or whether they have competence to make the decision. And this is very worrisome to me. So thank you very much for your comments, because I think it helped reflect on this.
Well, thank you. Yes, I thank you for pointing out those parts of the presentation from the Oregon experience. Yeah, I think what we have to keep in mind is that this started in the Netherlands in the 1980s. They had a long run-up to it, and so it's not surprising that this will become increasing, and I think it will continue to increase, and that our destination is Belgium or the Netherlands, and to think that it's not, it's going to be contained, and that it'll just be, very few numbers of people is I think naive. I think in terms of the presence at the deathbed, it's not only in assisted suicide, it's in all of medicine. It's part of the what we need to have in terms of reforming care of patients at the end of life. I mean, people are fleeing. I mean, very few patients die in the hospital, where there are thousands of physicians working here. There are very few cases, except when a code is called, that the physician is actually present. And many medical students will graduate from medical school without ever seeing anybody die. And I think that's a real problem. And that's the kind of thing we ought to be working to help fix, so that this picture becomes normative rather than here are the pills, go home and take them. Right? And then, yes, I think people fudge. That's part of what you can expect to happen, and you can expect as this becomes more and more common for there to be more and more fudging. And that's you've got to expect some of that when you're doing this. And if you don't want that to happen, then you shouldn't pass the laws. So, I don't know how much more time do we have, or okay.
I think we could take another 10 minutes.
Okay, good. Okay, good. All right, just.
Great talk. So you brought up the Netherlands and Belgium, which is really important because a couple of days ago, I think Belgium, the first case of a minor taking advantage of their law. And I think for the Netherlands, if I'm not mistaken, it's children over the age of 12 can partake. Do you think, is there a difference between minors and adults taking advantage of these laws? It worries me.
Yeah. Well, I think I think it's just another another example of the slippery slope. Certainly, with respect to general medical ethics, right? There are minors who can sort of understand basically what their medical condition is and participate in their decision making, and we usually ask in those cases for assent of the person, right? So the child will assent to treatment for chemotherapy while the parents sign the formal consent form, because we want them to participate in their care. But again, once you've made assisted suicide legal, what happens? It becomes clear then that, well, if this is a good thing, how can we prevent children from participating in it? It just becomes another direction in which we move, and it's worrisome to me. I mentioned also that in the Netherlands, and you didn't, there is neonatal euthanasia as well. So children born with spina bifida are just given lethal injections. And the parents request it, and it's been suggested by the doctors. That's how it's done. All of this I find terribly disturbing, and I think it's again where all of this will go. And to sort of say we'll contain it, it's not going to happen here, is just naive. It's just naive. So, in the front, yes.
I was just asking a clarifying question. In the case of a terminally ill patient for whom there's limited healing, they're dying, and they've decided to do themselves in for reasons that remain personal, are we talking then, is your argument about physicians participating in that, or do you think that act in and of itself by the individual is immoral by itself? And if so, who then should have the authority to make that kind of decision when the healing power of medicine ceases to exist other than the patient?
Yes. So it's a good question. My argument here has been about the legalization of physician-assisted suicide. I do also happen to believe that suicide is wrong, but that's not been the argument I've made here, and I can give reasons for that. There are those who would, so how would I handle it clinically if the person, I would try to argue, if somebody told me they wanted to kill themselves and I told them I wasn't going to help them doing that, and they said they were going to do it themselves, I would try to, argue them out of it. That's what I would do. And I would say, I continue to value you. I want to be with you. I want to accompany you. I want to make your last days as good as they possibly can. But I am not going to follow them home, right, and, police that. And if they do that, again, it's been, assisted suicide has been decriminalized. I would consider that tragic, but I wouldn't sort of as a matter of legal course follow them home and try to hospitalize them under those conditions. But I think it would be, and from another set of arguments that I haven't really made here, I think that would be immoral as well. But that's another set of arguments. I've argued just about physician-assisted suicide today. There are those who've made the argument that we should have other people doing it other than physicians. So other people can help them with it. Again, I think that would be better than having physicians do it, because I think that has even more moral problems. I still think that would be wrong, but it would be better than having physicians do it. Back, yes.
Thank you for so clearly sharing the position on physician-assisted suicide. What's your position on voluntary stopping of food and drink? Are you critical of a physician who assists a patient and provides palliative care over the course of the patient's voluntary and capacitated decision to stop eating and drinking in conditions where they're terminally ill and there are no options?
Yeah. It's probably worth another lecture, and I have given another lecture just on that. Let me say briefly that I think that certainly when there is a medical condition that either makes it difficult or potentially impossible for the person to eat, that I am not in favor of putting feeding tubes into such persons, right? So if someone has lost the ability to swallow in the end stages of Alzheimer's disease, for instance, I think there's actually good evidence that putting feeding tubes into such persons does nothing to actually prolong their lives, even though people have this instinct to say, oh, we have to feed them. What I would rather do for such a person, and I've told families who sometimes get nervous about this, even if someone is dying of cancer, they want to eat and they can't eat because they've lost their appetite at the end of the cancer. Can't we put a feeding tube into them, doctor? Well, no. What you should do is get a demi-tasse spoon and dip it into honey and put it under their tongue, all right? That way they can, there's an interpersonal interaction that way. They actually get some taste of it. It's more like eating. And the communal aspects of eating that are important. So I don't think that people who are dying need and have lost the ability to eat through cachexia or anorexia that accompanies terminal conditions like cancer, end stages of even untreatable multi-drug tuberculosis, multi-drug resistant tuberculosis. I mean, TB used to be called consumption, right? People lose their appetites. And so in that case, in those sorts of cases, I do not want to see people being voluntarily stopping. I don't think that they are voluntarily in some way stopping eating and drinking. I think it's involuntarily stopping eating and drinking. What I worry about is the patient who comes to the doctor and says, I've just been diagnosed with Alzheimer's disease. I, may have a 10-year prognosis. I foresee the possibility that I might get, my memory might deteriorate further, that I might become incontinent. My intention is to make myself dead by stopping eating and drinking, and I want you to sedate me so that I don't have any symptoms. In my view, that's just another form of physician-assisted suicide. Making that argument is, in greater detail, is complicated, but that's the way I would argue it. Yes, maybe our last. Okay. Yeah. Yes, yes, yes. Yes, 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 yes. So thank you for emphasizing that. I probably didn't emphasize the nurse's role in this as much as I should have. I don't know, I'm blurring together the two lectures, whether I talked about how even the hospice movement grew up as a grassroots movement of basically nurses and survivors of patients who died because the doctors were not attending enough to the needs of patients. And nurses have been there for from the get-go. And nurses are a critical part of the team in palliative care, as are chaplains, social workers. What I suggest, actually, is that the team-based model of care, which is part of what palliative care and hospice do so well, ought not just to be reserved for people who are dying, right? Not only moving palliative care upstream, but making this sort of team approach normative for all the care that we give in the hospital, because I think that's the best way to go to provide the very best care that we can for patients. And making more of that, what you're talking about, available to people is exactly the direction that I would argue we need to go. And part of the problem, I think, with all this talk about assisted suicide is that it distracts us from the really hard work of trying to improve palliative care in this country. Yes, yes. Yeah, they'd be given all the opportunities to have their symptoms relieved and know that they didn't have to resort to assisted suicide. Absolutely, absolutely. Yes.
A comment, and also just last to perhaps tie this together. One of the things we're seeing in California is that we are, in terms of the death certificate, essentially being asked not to list physician-assisted death, physician-assisted suicide on the death certificate. Mm-hmm. So actually for the use of a drug, right? So that's deeply concerning to me in terms of a basic moral concept of truthfulness.
That's right.
That if a physician is willing to write a prescription, then that they know will be lethal, that be honorable sort of in terms of truth.
Yes, yes. I agree 100%. That seems to me to be it's simply disingenuous to say, I think your law even says, aid in dying shall not be, considered suicide. Be like saying, lying under oath will not be considered perjury. This is sort of oxymoronic, but it's the kind of linguistic manipulations that Professor Del Oro talked about that's part of the movement here. It sort of papers over really severe moral questions by just sort of covering it in linguistic disguise. So,
and I think the last piece that I sometimes think that we've arrived here because we, through certainly the concept of liberty and autonomy, we over-treated at the demands of patients and families, and we created horrible deaths for the public to witness. And now, in a sense, after doing that for the last 40 years, we now are seeing the backlash of that, of yet again another form of autonomy, but it's actually trying to clean up the mess that we've been creating for a long time.
yes, and I would say it's not simply the giving for the last 40 years, the last 60 years of the sort of new technological era of medicine. It's not simply been honoring the autonomous preferences of patients. We've been co-conspirators. There are still. It's part of the schizophrenia of this, right? You've got some people who are still in the Curtis E. LeMay school of chemotherapy, better dead than leukemic, right? Just keep pouring the drugs into the person, and then you've got the people who are demanding feudal care, and then you've got the people who are demanding assisted suicide all at the same time. And so I think we're all partly responsible for the mess we're in. But I hope we can get ourselves out of it. All right, thank you. Thank you.
So we thank you for being here this evening, and we hope that you will join us next week. Again, be sure to get your emails if you didn't.